Hello, everybody. Welcome back to the Incubator Podcast. We are live at the Hot Topics in Neonatology Conference in 2024. Yes, the sign was off. It's okay.
That was my job to turn on and off the sign.
That's fine.
It's too big a job for me, I think.
No problem. No problem. We are joined this afternoon by our first guest, Dr. Risha Bhatia. Risha, thank you and welcome to the show.
Thank you for having me.
For the people who may not be familiar with who you are, you're the Director of Neonatal Services at the Royal Women's Hospital in Melbourne, Australia. So you come from far away.
Long way.
Far away. Melbourne is a good 24-hour flight away.
Oh, my.
It's funny because...
And we were just complaining about it.
Because PAS this year is in Hawaii.
Yeah.
So
that is an 8-hour flight away.
What?
That's an 8-hour flight.
I know. That's what we were saying. Because we were looking at it, we're like, my God, this is so far. And it's like 12, 14 hours, but 24 hours. So how many movies do you go through?
I went through about 4.
Nonstop, right?
Yeah, nonstop.
It's nonstop?
No. It's Melbourne through to LA was the flight I took, and then between the delays and things, and then to DC from LA. So
very interesting. Very interesting. Well, thank you for being here.
Yeah,
thank you for making the trek, of course.
Pleasure.
And you had a very interesting session yesterday about the session is called Decreasing Extubation Failure in Extremely Preterm Infants, the ECLAT trial. I love that name.
Because you get to use your French.
That's right.
Yeah. This is the holy grail of neonatology.
I mean, that's what we're all afraid of. It's like one more day. Don't try to extubate on my shift.
Notably, Ben is excellent at extubating on his shift.
I am not. I'm a kind of a reckless person.
Yeah, Ben's like, you know what? I
pull out that tube.
I
Well, that's the
extubated
right
this
attitude
baby
to have.
1 hour before your shift. That's what he says.
So can you tell us a little bit about what are the pearls, the takeaways from that session on the ECLAT trial and some of the lessons you've learned about successfully extubating and understanding the babies that are probably primed for extubation?
Yeah, no, thanks for the question. So the ECLAT trial stands for the Extubation CPAP Level Assessment Trial. We started that trial because one of our NICU nurses who watches these babies and extubates them, and sometimes it happens like that.
Yeah, big bang.
Big bang. Came to us and said, how do I keep babies off ventilators?
What a lovely start to your story.
Yeah. So it's all about observation, right? Standing next to the babies, watching them, seeing what they do, seeing how they behave. And we were worried that we had a relatively high extubation failure rate in our organization, so we wanted to bring that down. And some of the work that I had done previously was looking at sort of the physiology around how the lung behaves during extubation. And we found that babies do lose some lung volume when you extubate them, and they don't regain that lung volume too much even after you've put them on CPAP. Yeah. So we wondered about how much pressure we were giving. And there's been some work sort of at least a decade ago, which had some conflicting results. So we took on the ECLAT trial, which essentially asked the question that in less than 28-week babies, did extubating them to a pressure of 10, which is higher than most American units will use, versus compared with a pressure of 7 centimeters of water, for example, would that decrease extubation failure in the first week after extubation? And so that was a randomized trial done in 3 centers in Australia, 1 in Brisbane, 2 in Melbourne. Unfortunately happened during the COVID pandemic. And some of you may know that Melbourne sort of had one of the harshest lockdowns worldwide, probably, if not, well, certainly in Australia, if not worldwide. And so we didn't quite meet our sample size. But what we did find was that if you did extubate babies to a CPAP of 10, you kept them off a ventilator, more so than if you extubated them to 7. Despite that, and despite sort of successful results and, what we thought was a great answer, there are some limitations to that study. We didn't meet our sample size. So if you talk to the statisticians, there's been some really great talks about statistics and bias and what happens if you don't meet sample sizes at this meeting. So, we didn't. So we've got to consider that. We should probably replicate the study. Somebody needs to look at it again, make sure that, we got it right. And of course, we've got more to do in that space because there are still babies not succeeding well, actually, babies don't fail. It's the therapy that fails. So extubation failure is still occurring in these babies.
What I love about the whole concept is I think there's this mantra: if you never have any, babies who, you're right, who we fail in extubating.
If you have a 100% success rate at
That's right. You're
extubation
just
rate,
not extubating them soon
You're
enough.
not. That's
But
right.
there is a skill to extubating
There
and
is.
maintaining babies and maintaining that functional residual capacity, so that way that we set them up for as much success as possible. And when you're a trainee, you're like, oh yeah, tube in, tube out. We figured this CPAP +6 +7 thing out, but we really haven't.
No, we haven't.
And I love that you guys are looking into that, giving us hope that maybe there is a way we can be more successful. And I think it's just a reminder for, young clinicians that there's so many unanswered questions. If you just look at your practice, can we change just one little thing to potentially really change outcomes for babies? I think it's incredible.
Yeah, no, thank you. I mean, it's has it changed practice for us? Well, certainly there's practice creep. Our unit has changed. In fact, I think all the units have changed their practice a little bit. But I think what we need to do next is actually audit that. And again, at the meeting here, there was this sort of great day prior to the meeting starting on quality
QI,
and the QI group. And so I think taking some of those ideas and thoughts away from the quality improvement people to see follow through from a study point of view and make sure that that's what's happening to our babies who are now no longer part of the randomized control trial. And that practice is maintained and no other strange practices are creeping in. And that they're still doing what we expect them to do, which is stay off a ventilator, is still in practice. So I think that's really important. And I'm hoping that I'll find a fellow or somebody who's interested in that quality improvement
So
project.
if anybody's interested, they should contact
Come
you.
and contact me, absolutely.
But what a great idea in how to follow up some of these studies, right? Because you guys are continuing the practice, and that's a lot more babies that could potentially be studied. I think that's a really exciting opportunity.
A different way of looking at it.
When it comes to extubation, I think there's a few things that make the study of extubation so difficult. Number one, we don't really have a good sense of who, like we were talking about this with Cindy McAvoy earlier about, hey, these babies are on something because they need it, but they're needed because they're on it also. So we're not exactly sure if it's us that are just too conservative or if the babies truly need that level of support. Plus, we don't really know how to define extubation failure. So if you remain extubated for 12 hours, 24 hours, 3 days, 5 days, 7 days, what truly constitutes extubation failure? And the word failure is terrible, by the way, because if
we should call it, extubation success, right?
Or at least, but even if you can stay extubated for 3-4 days, it gives you plenty of information as a clinician to say, okay, there's a lot to work with here. A baby that fails within 30 seconds of being extubated tells you a great deal of information as well. So I'm just curious about how you're navigating all these tediousness of definitions and what do we consider a proper extubation time, extubation failure. How do you use that in terms of just reviewing the prior literature and staying consistent, or trying to maybe even redefine that?
Yeah, great question. So we decided on 7 days, and the literature has a whole range. So the two studies that have sort of done similar work a decade ago, the first study looked at a small number of babies, and that was the Kitsamart paper. They extubated to small babies to 5 versus 8, and the primary outcome was over the 72-hour period, and found no differences in the groups. The study the year after looked at extubation failure in 96 hours, and they found some difference. And that was the Bazella paper. And then sort of we looked at it a week. Now, when you look at our data, actually, it's in keeping with what both Kitsamart and Bazella found. The majority of babies experienced extubation failure in the first 72 hours. But in our study, no baby, certainly in the high CPAP arm, failed or experienced extubation failure after the 72-hour mark. So we're not on top of it. The babies in our study experience extubation failure because of apnea, and no amount of CPAP is going to help apnea, right?
There's no PEEP level that will fix that.
So we've got to go
really
back
useful
a step.
information, right? Because maybe there's something we can add to our bundle to help.
Careful, Dr. Schmidt told you about caffeine earlier.
I know.
Just be careful.
And actually,
but what about these are babies that are already on
these
caffeine?
Are babies on
maybe
caffeine.
They need a little more. Maybe they need a little boost.
Maybe they do,
like our anesthesia colleagues are doing.
Daphna's the barista of our units.
Yeah.
Oh, I tell you, can't get through my morning coffee. Need the morning coffee to get going.
I had a delightful attending from Colombia, and she would say, "This baby needs more coffee."
I want to make sure because I'm the medical director. So you're not giving coffee to the staff. I'm saying the barista for the babies. That's what I meant.
We're also in South Florida, so lots of people are giving lots of coffee.
There's
to the
always
staff.
coffee somewhere,
Somebody's making coffee.
I just want to make sure that the joke
I love
comes
the
across.
Caffeine.
Yeah, for sure. No, this is super interesting, and obviously this is a subject I think that everybody. It's the first question that most people who are training, rotating through the NICU are asking, like, "Ooh, what kind of PEEP can I use? Like, how high is too high?" And I think that. When I was training, at least we would not consider a PEEP of 10 on a smaller baby, and it's like, oh, that's forbidden.
I remember the challenges when we were putting the study together, because that was exactly what people were wondering about. What are we going to do? And so we had strict sort of adverse event criteria after discussion. Pneumothoraces is a huge problem. We didn't see it in the study.
No,
perfect.
Pulmonary interstitial emphysema, huge problem in that tiny baby group, and half of our population was the 22 to 26 week, 22 to 25 week bracket. So we didn't
Which
see
is
that
incredible.
too much
the number
either,
of babies
right?
you had that were quite small.
Yeah. Yes, thank you. And again, that's sort of through the altruism of our families and infants, and who wanted to be involved. We can't do this work without families. But I think it did answer a question for us. We've still got to be careful about it, though, for the various limitations that I talked about in the at the talk yesterday.
For sure.
Yeah.
Risha, thank you so much for dropping by the booth and for sharing with us some of the work that you've presented. Congratulations.
Thank you.
And we're looking forward to the follow-ups.
For sure.
That's right.
Yeah, well, hopefully. Well, thanks for having me. It's been great meeting you.
Brett, if you're, I don't know why you moved to a different institution. This sounds like a lovely thing to work with Risha.
He's on the paper.
He'll recognize himself.
Yeah, he will. All right. Thank you.